that Baxter uses. We'll try to briefly go through those. Okay, we'll try to briefly record or go over those. The first thing is, everybody all of our drug reaction with IV, IM. It can be intermuscular. And it can be intertracheal through the spinal cord, beneath the skin is subcutaneous. We can have it placed under the tub, which is sublingual, or between the gums, which is buccal. You can also deliver drugs through the rectum or the vaginal, rectally or vaginally. Another method is through the eyes or the ocular route, or through the ear on the optic route. Also, you can do it inhaled through the nasal airways, through the mucous membranes and the nasal. You can breathe it into the lungs by inhalation, or it can be nebulized. It can be applied to the skin for a local or topical body-wide symptomatic effect. It can be delivered through a patch on the skin, which is transdermally, and that's a systematic effect. We do not deal with all those on the ambulance, but we do deal with a lot of those. The first one we're going to talk about is the oral route, which everybody knows is through the mouth. Some of our drugs that we deliver orally is mainly the aspirin. We'll talk about the different ones, but when we go through all the drugs, we will introduce the different routes that they take. We don't really have that. We do on the ambulance, but muscular, we do the veins, we do the let's see, when we give Narcan through the nose, we do that. We do the inhalation. We do the sublingual with our nitro, and we also the route to the bone marrow when we do it IO. Everybody's familiar with the tools we use. Used to be when we did IOs, we actually had to push and turn until we heard a pop. Now we have the guns, which just drills it into it. When our IV access is not available or feasible, readily available, usually you see us use the IOs when we're doing codes. If you do an IO with a patient that is alert and oriented, then they recommend you do the lidocaine first to numb the spot. There is different locations. I'm not really sure on the new Baxter protocols where we will be doing those, but the sites that you can use is the upper tibia. You can use the femur, the humerus, or the superior iliac crest is where the IOs can be done. On our ambulance medication inventory, I thought it would be a good idea to go over the different drugs, just kind of get brief of them. The center of adenocard. It's a slow conduction through the AV node. It can restore normal sinus rhythm in patients with PSVT. Your conversion is you want to try your vagal maneuvers prior to giving adenocard. And it does not convert your atrial flutter, atrial fib, or ventricular tachycardia. And it is contraindications are second and third degree block and sick sinus syndrome. And also somebody who's very hypersensitive to adenosine. The effects you can expect, side effects would be a facial flushing, a headache, sweating, palpitations, dyspnea, chest pressure, lightheadedness, dizziness, tingling in the arms, numbness, blurred vision, neck and back, nausea, and tightening in the throat. Those are side effects. On your dosage for your adenosine, it's going to rapid IV. Your initial dose will be 6, and then it's a rapid IV push over 1 to 2 second period, and it's followed by a 10 cc flush, normal saline flush. You can repeat the administration with a 12 milligram rapid followed by flush. With this one, in order to do this procedure, they want you to administer a large bore 18 gauge or larger in the humeral IO or with the humeral IO at the AC or higher, and then immediately flush it with a 10 cc normal saline flush in a fast push. So what I've seen that's different than our protocols right now, it doesn't specify it has to be an 18 gauge or larger. On Baxter's, they want you to use an 18 gauge or larger in the AC or higher. So that's another difference that we might think about when we're given adenosine. Their next drug we're going to talk about is albuterol. Yes. And a lot of us are familiar. We all use albuterol drafts. It's a relief of the bronchospasms in a patient with reversible obstructive airway disease and acute attacks from bronchospasms. The counterindications is a patient with a hypersensitive to component. Now, the adverse reactions can produce paradoxal bronchospasms. If this occurs, you need to discontinue immediately and find alternative therapy. The alternative therapy to albuterol on here, I haven't went through all the protocols, so I'm not really sure what the alternative is going to be. What do you think they would be? We used to carry albuterol and Duoneb. We don't carry Duoneb at Fulton County. Now, when I go through here, I will see if they do, but I'm thinking they don't carry Duoneb. So in that case, what would you do, Tasia? Because we won't have another alternative drug for that.
Racemic epi have a mineral on it? When we give it?
I don't know if that's a mix or not. Can you look at if we don't have an alternate drug for albuterol? And I'm not even seeing racemic epi on our list for
what is the
Baxter.
alternative drug for albuterol? Benylin. Subcutaneous saline, levobuterol, Pro-Air.
A lot of them will have their breathing apparatuses they use, and that might be something that they have taken already, but good question. Your precautions would be patients with cardiovascular disease and diabetes and hypertension. The effects of this drug is a beta energetic action affects the respiratory tract in form of the smooth muscle relaxations. The side effects can be tremors, dizziness, headache, nausea, tachycardic, over manifestations, including angina and hypertension, which is why you need to be very cautious with the drugs when you're doing that. Your updrafts, they're all pre-vials that we use of the 2.5. And, you know, it has different doses for the children's and the adults in the nebulizer. We're going to be, most of those all are familiar with that. We've used them. I know over the years, our next one's going to be ammonia inhalants. We've used them on different ambulances and different services. They've been pulled, they've been put back. Well, Baxter does carry ammonia inhalants. So, but right now they carry them. Yes, and their protocols, they have not changed their protocols. They are carrying them now. If they take them off, they take them off. But as of now, we're going over the protocols they gave us that we'll be incorporating in ours. And ammonia inhalants is on them. So, the effects are offensive, noxious odor, unconscious individuals, secondary to fainting or emotional shock. You can use those on. Counterindications, do not allow the capsules to rest or touch the skin of the patient. You can have allergic reactions, rash, itching, swelling, and dizziness. So the dosage is you crunch the ample, wave it under the nose for less than 10 seconds. The crushed ampoule between her and wave it under the nose is the way you give the ammonia inhalant. Theft is another drug we keep on our trucks now, and we will continue. Suppression of bacterial growth, used primarily to prevent infection in open bone fractures and open injuries. The counterindications for this, they're patients with hypersensitive to any of its components. Your precautions will be seizures have been documented in patients that have kidney problems that's been given Ancept. Your side effects could be GI irritations, diarrhea, nausea and vomiting, itching, rash, fever, and pain at the injection site. We will need to do the dosage of the Ancept is 2 grams and 100 cc's of normal saline is the preferred ratio, and you administer it in 10 to 20 minutes in an IV drip, which we're familiar with that one. That's one of our normal drugs, okay? We're going to talk about aspirin, but everybody knows aspirin's something we've been using forever on all the trucks, okay? The management is inflammatory disorders. It's for treatment of fever, treatment of moderate pain, prophylaxis of myocardial infarction, and prophylaxis of transient TIAs. The contraindications is hypersensitive to aspirin, terrazine, which is the yellow dye number 5, or other silicides. Okay, don't know all these big words. Okay, bleeding disorders, severe renal or hepatic disease. Some of your side effects, of course, you're going to be your heartburn, your gastric distress, nausea and vomiting, GI bleed, etc. Our doses will remain the same, 81 milligrams times 4 of the chewable baby aspirins, preferably PO. Give to the patients even if they've already taken aspirin. Over the years, they said if they've taken aspirin at home, don't give it to them. On Baxter protocols, we were told that even if they took aspirin, go ahead and give it to them. So that could be a change in the way some people are used to doing that. Before, if they'd had aspirin, they wouldn't give it to them, but they want you to go ahead and give it to them. Okay, with atropine, is for sinus bradycardic with PVCs and hypotension, 2nd or 3rd degree blocks, asystole and organic phosphate poisoning. The counterindications are for atrial fib flutter with rapid ventricular response, RVR, glaucoma, and be caution in MIs. Okay, your side effects can be blurred vision, headache, dilated pupils, dry mouth first, and flushing. Your dosage for your bradycardic patients is 0.5 milligrams IV push every 3 to 5 minutes with a max of 3 milligrams. For your organic phosphate poisoning, it's 1 milligram IV push every 2 to 5 minutes per protocol. Your pediatric doses will all be less than your adult doses, and that's 0.02 milligrams a kilogram IVIO. It may be repeated once. The minimum dose is 0.1 milligram, maximum is 0.5. So that hasn't really changed any. Okay, your calcium is used to reverse your OD of the mag sulfate and relax muscle spasms. The indications is an antidote to mag sulfate and black widow spider bites. So it is it's indicated if they've had a black widow spider bite. Your contraindications is caution and DIG, which you
What are we
need
on?
calcium.
Oh, sorry.
You're way behind me. There we
I'm
go.
sorry.
Okay, so calcium can be used for black widow spider bites, which is something I'm learning. And of course, it's the antidote to mag sulfate. Your side effects in patients with DIG or when pushed too rapidly can cause VFib. These are slow IV pushes. Adenosine is our one drug we've already talked about that is a rapid IV push. Most all other drugs are slow IV push. Got a cold, guys. Sorry. With your calcium, you want to do a slow IV push, 10 milliliters of a 10% solution. 1 milligram total is all you want to do with your calcium. But I did not know you could do this for black widow spider bites. So I've learned something today. Okay, cardizem. We use that for SVT conversion of atrial arrhythmias, including atrial fib with RVR, atrial flutter, and PSVT. Your counterindication is sick sinus syndrome, second and third degree block, and severe hypotension. Caution if they have hepatic disease, CHF, pregnancy, or lactation. Your side effects on your cardizem could be a headache, fatigue, arrhythmias, edema, hypotension, nausea, sweating, palpation, tremors, vertigo, rash, burning, itching at the IV site, and it may increase your serum digitoxin levels. Okay, so your dosage for your cardizem is 20 milligrams IV push over 2 minutes is your adult dosage. Assure medical control is advised of the patient's age and weight when you give cardizem. An elderly patient may need reduced dosage, which we know on all elderly patients, they do not metabolize their drugs the same. The onset of the IV should be 2 to 5 minutes. Your procedure is you begin an IV administration of 20 milligrams over 2 minutes, then after 5 to 10 minutes. If no improvement and the patient remains hypertensive, rebolus with a 25 milligram IV over 2 minutes and consider an IV maintenance drip on your cardizem. Your dextrose is D10. We use that for hypoglycemic, coma of unknown cause, static. Say it for me, Tasia. Static.
Where are you at?
Dextrose.
Status epilepticus.
Yes. Okay. And refractory cardiac arrest. Cautions are intracranial hemorrhaging. The side effects can be severe neurological symptoms in alcoholics. You need to give them thiamine, 50 milligrams IV and 50 milligrams IM of the pre-dextrose administration. Tissue necrosis if not given in a large vein. So this is another thing they want you to go to the large vein with. Your dosage is 100 cc's of D10, 25 grams in a 250 cc bag over 10 minutes. The blood glucose reading should be assessed after 10 minutes. Then if after 10 minutes, the reading is greater than 60, or if the patient is less than 60, or if the patient has not regained consciousness, continue dosing at the above reference rate. So I did not see, when I was looking through here, D50 on the list anymore. So when we switch over, do you see it on there anywhere?
What is it? Sorry.
D50. I don't think we'll be carrying D50 when we switch over to Baxter protocols.
No, our next one is
No.
battery.
So we will no longer have that. Right now we have D50. We use it very rarely because we have switched to D10, but we do have that if needed. And I don't think we're going to have that anymore. Now we are on Benadryl. Benadryl or diphenhydramine blocks the histamine effects. refers to some of the effects, inhibits motion sickness, and anti-medic. Your indications are anaphylactic shock used for severe allergic reactions. You can use it with epi 1 to 1,000. The counterindications are asthma, glaucoma, come on, help me out here. Asthma, glaucoma, I can't even talk today. Glaucoma, prostate enlargement, ulcer disease, and SS obstruction in pregnancy. With your dosage on your diphenhydramine, you want to give 10 to 50 milligrams IV or IO or IM per medical control. Now, I'm not sure with these protocols if that means anytime, which I need to find out. Does that mean we have to call medical control anytime we give Benadryl, or only if we're doing it other than IV? I don't know. Do you know? Do we have to call medical control to give diphenhydramine?
I've never seen a call.
And maybe it's like per medical control for your IM. If you want to give it IM, I don't know. So we'll have to find out what that is exactly meaning, because I don't know. Okay, and dopamine's our next one. Okay. All right. We got dopamine, which we're familiar with that. It's a beta sympathetic. It increases rate and force of the cardiac contractions, dilation of the renal and mesenteric arteries, promotes urine flow. It's an alpha effects at a higher dose. Okay, contraindications is cardiogenic shock and hypotension, and bradycardia resistant to atropine. That's your indications. You want to use that if they're in cardiogenic shock, hypotension, or bradycardic, right, resistant to atropine. Your contraindications is for hypovolemia without a fluid replacement, uncorrected VFib or VTAC, and you do not want to mix this with Bipar. All right, your side effects can be atopic beats, palpitations, tachycardic, nausea, and vomiting, dyspnea, angina, and headache. Dopamine is an IV infusion of 2 to 20 mics a minute. I remember y'all talking about that one of the other classes. It's 2 to 10 micrograms a kilogram a minute. That's where you get the kilogram. And your cardiac dose is 5 to 10 micrograms a kilogram a minute. Your pressor dose is 10 to 20. Your pediatric is 2 to 20 micrograms a kilogram a minute IV. So that's not really changed. Our epi, we use for cardiac arrest, anaphylaxis, asthma. There is no counterindications in cardiac arrest or anaphylaxis. You do want to proceed with caution with angina, hypertension, and hypothyroidism. Your side effects could be palpitation or tachycardic and elevated BP. Our dosage is the same as always. Cardiac arrest, it's 1 milligram to 1 to 10,000 IV push, IO push. Or 2 milligrams, 1 to 10,000 ET tube, repeat every 3 to 5 minutes. For your anaphylactic reaction, it's 0.5 milligrams of 1 to 1,000 IM. For asthma, it's 0.3 to 0.5 of 1 to 1,000 IM. And then, of course, your pediatric doses are listed also. A drug that we have not carried in the past on at Fulton County is your etomidate. Your etomidate is a sedation for our RSI. Known sensitivity, counterindications, use in pregnancy only if the benefit justifies the risk. Do not use during labor or nursing mothers. Your side effects are hypotension, post-op nausea, vomiting, temperature, involuntary muscle movements, hyperventilation, hypoventilation, laryngeal spasms, hypertension, cardiac arrhythmias. Your dose for your etomidate is going to be 0.3 milligrams a kilogram. It's going to be a slow IV or IO over 30 to 60 seconds. Your RSI is going to be 30 milligrams a slow IV. You want to consider 10 milligrams in elderly or patients with cardiac conditions. And then, of course, your pediatric doses are in there. So etomidate is one I'm not familiar with, and we will be carrying it on our trucks for people that have been certified RSI. From what I understand, they have to go through a class at Baxter to get that, but that is going to be one of the new drugs we'll carry under their protocols. Okay, the next one we're going to talk about is fentanyl. Fentanyl is a narcotic and, all right, help me out here. Analgesic. It's for pain management. We do give fentanyl here, so a lot of us are familiar with it. Your supply dose is 50 micrograms ml for pain control. For RSI, it's 50 micrograms. IV, you've got your IV, IO, IM, and IN bolus, 50 micrograms over 5 minutes until the pain improves. Your intranasal administration is the fastest, most effective means to use fentanyl, which I've not used it like that. I don't know if anybody in here has, but it's supposed to be more effective. So a max of 150 micrograms, patient sedated, sedation, contact medical control if no improvement of pain. Post-intubation bolus is 50 micrograms over 5 minutes until the desired sedation. Contact medical control for a further dose. So fentanyl, y'all are pretty used to because we've been carrying that on the truck for a while. Glucagon is another one that we carry on our truck also. It's for the acute management of hypoglycemia when when administration of glucose is not feasible. Used to terminate the insulin shock therapy in psychiatric patients, used to facilitate radiographic exams in a GI tract. Glucagon stimulates the hepatic production of glucose from glucagon stores. It relaxes the muscular nature of the GI tract, has positive entropic and chronotropic effects. The contraindications to glucagon if they have a hypersensitive to beef or pork, which I did not know that. That's a new one on me. Yes. Avoid in patients with hypersensitive to these ingredients. It can cause nausea and vomiting. Sub-Q and IM is 0.5 milligrams to 1 milligram. And of course, your pediatric dose is under 44 pounds of 0.5 milligrams sub-Q or IM. So according to this, glucagon is only supposed to be used as a shot, sub-Q and IM. All right, we got another, your oral glucose, guys, everybody's used that. It's a tube. Just make sure that there's no contraindications other than they have to be alert enough to swallow. And that's the only thing. You know, you don't want to stick something in their mouth if they're not alert enough to swallow that they can aspirate on. So oral glucose. There's really not a whole lot on that one. Ketamine. Ketamine is another drug that we do not carry on our ambulance here. It's for moderate pain control, chemical restraint for combative, psychotic, and behavioral emergencies. So those are the reasons we would use that on the ambulance. Okay, on your low doses, your NMDA receptor agonist, it enhances the DA activity of the AB agonist with your augmented opioids and C fibrosynapsis. On your high dose behavioral, it's this dissociative effect. It's a psychological disattachment and decrease in locomotion.
So that's what the game that we played, the Jeopardy game.
Mhm.
That was
The dissociative effects. Your counterindications in a patient with significant elevation of the BP would be considered a serious hazard of those known with a hypersensitivity to the drug. Ketamine is a contraindication in a patient with a significant elevation of the BP. Your side effects could be elevated BP, elevated heart rate, cardiac arrhythmias. Rapid IV administration can cause respiratory depression. Once again, this is not going to be a rapid infusion. Nausea, vomiting, and tonic-clonic like skeletal movements could be a side effect from ketamine. You want to give 25 milligrams as a say it for me, analgesia. Yes, it'd be 25, and then agitation would be 4 milligrams a kilogram, and that's your adult dosages. So those are the reasons we would use ketamine. All right, Lasix. We've had Lasix forever on our trucks. Lasix is a potent diuretic in large volumes of urine within 5 to 30 minutes. It's also a powerful vasodilator. It's for your CHFers, your pulmonary edema. Counterindications are pregnant women with hypokalemia. Your side effects, nausea and vomiting, potassium depletion, and dehydration. On Lasix, it's saying you want to give 40 milligrams slow IV, 80 milligrams plus if they're already taking Lasix. So if you get a patient, then this has changed because ours weren't like that.
Yeah.
Mine used to be, you give them, instead of giving them, we got 20s and 40s. And according to this, you want to start out with the 40 if they've never taken Lasix, but if they have taken Lasix and they're having an episode, you need to give them the 80, which is different in here. So all right, let's move on to lidocaine. Lidocaine, we're all familiar with lidocaine. It decreases excitability of the heart muscle, decreases cardiac conductive system. Your indications are PVCs are frequent with an MI, salvosis are on T, multifocal, and prevent VFib. Prevent reoccurring VFib and VTAC. Your counterindications is allergic to the locals Novocaine, or second and third degree heart blocks, sinus Brady, and sinus arrest, and idiotracheal rhythms you don't want to give lidocaine for. Your dosage is 1.5 milligrams a kilogram IV push and repeat 0.75 milligrams a kilogram IV push every 2 to 5 minutes with a max of 3. So that hasn't changed. It's still a max of 3. Your drips are 2 grams in a 500 of normal saline, which would equal 4 milligrams a milliliter, and your rate would be 3 milligrams a minute. All right, Ativan. Okay, Ativan depresses the CNS, probably the most potential GABA amino butyric acid.
Sounds good.
Indications are the induction of the management of anxiety and insomnia, provides preoperative sedation, it relieves preoperative anxiety, and provides amnesia, which I didn't know that.
Really?
AMNESIA, yeah, amnesia. Okay, your counterindications is hypersensitivity, cross-sensitivity to other benzodiazepines may exist in then comatose patients or those with a pre-existing central nervous system depressant, uncontrolled severe pain, or narrow angle glaucoma, pregnancy, and lactation. Your side effects are dizziness, drowsiness, lethargicness, paradoxical excitement, headaches, blurred vision, respiratory depression, nausea and vomiting, rashes. It's your first line for seizures. So we won't have diazepam anymore. We will be going to this. We'll be going to Ativan. The first line for seizures bolus is 2 to 4 milligrams IV over 3 minutes or until desired effects with a max of 10 milligrams. If you need more, you have to contact medical control on this. But this is going to replace our diazepam. Your mag sulfate is an anticonvulsive in severe eclampsia or preeclampsia, calcium antidote, and towards DePoints. When we have towards, that's when we give mag. It's a central nervous system depressant vasodilator. Your contraindications are renal disease, heart block, or myocardial damage. Your side effects could be respiratory depression and cardiac arrest. The mag sulfate dose is 2 to 4 grams IV, mono respirations, and deep tendon reflexes, knee jerks. If absent, consider calcium gluconate dose of 10 milliliters of 10%. For towards, you want a slow 2 grams IV push. Have you ever given mag for towards, Tasia? You? Okay. So that's one we've carried. Versat is another one we do carry. It's a sedative, moderate sedation, and seizures is what we use Versat for. For seizures, it'll be 2 to 4 milligrams, slow IV push, titrated to the effects. The adult dose for sedation is 0.5 milligrams to 2.0 milligrams IV, and then titrate. And the lower doses for patients over 60. So that's our Versat. Our morphine, we've carried for years. Decreases pulmonary edema by pooling blood in the peripheral circulation and reducing venous return to the heart. So the indications is pulmonary edema associated with CHF to relieve pain in MIs and other selective conditions. The counterindications is hypotension, respiratory depression, except with pulmonary edema, asthma, COPD. Patients who have taken other depressant drugs, head injuries, or diagnosed abdominal pain. With morphine, side effects, you can expect hypotension, bradycardic, respiratory depression, nausea and vomiting, and urinary retention. You want to consider when you're giving morphine to give them Zofran, 4 milligrams IV for nausea. A lot of patients get very nauseated when you do your morphine.
One thing that I do not like, you guys only carry Zofran, you don't carry Finagrin anymore. And I like the way that Finagrin exacerbates.
We've got something that they do carry.
They do carry. Well, they pulled it for a while.
I'm pretty sure they're. I think they do. I think we looked for it and we thought they didn't, but I think they do carry it.
We carry no
Yeah.
But Finagrin does something different.
Finagrin actually has a pain relief.
Yeah.
So patient is not the pain relief.
No, we'll get to it here in a minute, but
I don't, unless they put it back in, they didn't have it as of last year.
we were looking for the alternative for it. I thought there was something in here. Here, look at the list and see if you see it on there.
Yeah.
I thought it was because we were looking for the alternative. If they were allergic to Zofran or couldn't take
We're
Zofran.
good.
Yeah. So I thought we did, or they did. Excuse me. I thought they did. So, because I looked that up when we talked about it before. Okay. Okay, we did go through morphine. Okay, we're on Narcan, which everybody's familiar with Narcan. There's different routes of Narcan. Your effects is the antidote for narcotic agents, reverses the actions of all narcotic drugs, will reverse stupor, coma, respiratory depression, etc. These are due to narcotic overdose. There's no counterindications for Narcan. Too rapid administration may induce nausea and vomiting and ventricular dysrhythmias. To people that are dependent on narcotics may cause acute withdrawal syndrome. For this reason, Narcan should be given slowly using respiratory status as the endpoint. Note the duration is shorter than that of a narcotic, and it may be is being used to counteract. Patients may fall back in the stupor as the Narcan wears off. Patients should be watching Narcan repeated if necessary. Narcan is a slow IV injection. Draw up to 2 milligrams in a 10 ml syringe. Fill the remainder with normal saline concentrate. And then 0 grams a milliliter, and then monitor the rate and the depth of the patient's respirations. If no response to the full dose of Narcan, be repeated in 5 minutes. Now, this does not say we can give it nasally. Do they not give it nasally over there? Okay, so it's not on here, but nasal is another way we can give Narcan. Nitro, everybody's familiar, increase in cranial pressure, glaucoma, hypotension is their counterindications. Inferior MI with ST elevations, lead 2, 3, and AVF, do not give nitro. It relaxes the smooth muscles, relief of pain of angina, decreases myocardial oxygen demand, promotes pooling in the blood and the symptomatic circulation, and decreases the resistance against which the heart may pump. And it may be useful in CHF. Okay. Your effects are transient throbbing headache, hypotension, dizziness, and weakness. Your dose on your nitro, a patient should be in a semi-sitting or recumbent position, and administer 0.4 milligram tablets every 3 to 5 minutes to relieve pain, up to 3 tabs. Do not administer without IV established. So we all know that. Don't give Narcan or nitro if you don't have an IV established.
Well, I don't know what some of your stuff is on tonight for part of your patients. You will also change files. And so depending on how it reflects, because you need one nitro or something. On those, I usually wait for the 5 minutes to administer second nitro just because it may not reflect in your first blood pressure. I've had that happen multiple times. As a result, if I give it a second or third nitro,
We need to move on. We've got another speaker.
How are we doing on our time? Yeah, I was supposed to be done. Okay. Okay. Our next one is oxytocin. How do you say the P? Oxytocin. I have oxytocin. Okay, it stimulates urine smooth muscle contractions. Indications is postpartum control bleeding after an impulsion of the placenta, induction of labor at term, and facilitating of urine contractions at term. Your counterindications are hypersensitive to the drug and anticipated non-vaginal delivery. Don't give this. Okay, the side effects are maternal CNS seizures, coma, cardiac hypotension, abrupto placenta, painful contractions, fetal CNS, IC hemorrhaging, and respiratory hypoxia and arrhythmias. A piggyback solution of 10 U's in 100 milliliters normal saline into the main IV line, right at 125 milliliters an hour, 20 minutes, 20 MUs a minute. Infusion weight may be adjusted to control urine, to control the contractions up to 180 milliliters an hour, or 30 MUs a minute. Have you seen this in your truck? Pitocin. I'm talking to him. It's on index 48, so.
I think those protocols are newer. James gave me these last year, so, and he told me there was supposed to be an updated set. So he must have given.
This may be the
Yeah.
new one. Okay, sorry guys, you don't have it, but It's the one that I had pulled up on mine that I was given. Okay, let's get through this really quick. I'm gonna see, Finnegan, we're all familiar with. We've already talked about it. Here it is. We're gonna move on to ROC. ROC is a new one. It's used for paralyzing skeletal muscles, including respiratory muscles. When we're doing intubations with sucks, it is contraindicated. So you want to use that. Your contraindications hypersensitive to the drug. It is side effects, anaphylaxis, bronchospasms, hypertension, tachycardic, excessive salivation. Your dose is 1 milligram a kilogram IV push, set dose of 100 milligrams. That's a new one we're going to see. Romazicon is another one. It's a benzodiazepine antagonist. It reverses the benzodiazepine effects. It's management of potential or accidental overdoses. Patients involving benzodiazepine for life-threatening problems as of seizures, ICPU, serious cycle antidepressant overdoses. You don't want to give it. Your adult dosage is 0.2 milligrams IV push over 15 to 30 seconds. Sodium bicarb, we've done. We got sucks. Sucks, our dose for that will be 150 IV push over 10 to 30 seconds. And it is when you're going to do your intubations, RSI. You can read the counterindications later. Thiamine is one we're familiar with. Labetal. Let's see if there's anything different about that. Labetal. Control of blood pressure and severe hypertensiveness. I'm not sure. I'm not seeing you have to contact medical control before you give this. We do now. So I'm not sure without reading all the rest of the protocols if this is going to be one that we can give. And it doesn't also show the range on here is what the blood pressure needs to be. So I'm sure that's in with all the other stuff in the protocol book that we'll have to look up to make sure we're pushing that right. I think it used to be 220 over 120. Okay. Our next one is Macroman. How do you pronounce that?
Are you on TXA? What do you want? Becaronium?
Yes. How do you call it? Becaronium?
Becaronium.
Okay. That one is indication post intubation or RSI. That's 0.1 milligram a kilogram IV push, which is another one I'm gonna have to get familiar with. Okay, and our last one, Zofran, which we all are very familiar with that. Your dosage is adult 4 to 8 milligrams IV push and IM. So we're trying to rush through this because we got another speaker.
Thank you. Thank you. Thank you.
Wasn't able to answer all the questions, but when we get through the protocols better, we'll be able to.
Do you need to leave soon or can we take a break? Okay, you can take a break. All right, so we're gonna take a break and we'll be back in about 10 minutes.